though Vienna won the most livable city this year, the voting must have been stacked because I think they're wrong. Anyway, I've been asked to give an overview of the activities that are currently underway in the Australian Genomics Health Alliance. And so what I thought I'd do is just set the scene a little bit about what genomics is and what it has to offer, and then talk about the alliance, and then in particular I'll focus on what it means for families with mitochondrial disease. So I don't need to labour any of the points on this slide. I think that's been covered by other speakers. The one thing I would say is that there are two genetic systems involved. There are the genes on chromosomes, called nuclear genes, and then there are genes within the mitochondria called mitochondrial genes that can contribute to causing mitochondrial disease. And so that makes the genetics of mitochondrial disease really quite complex. And as a general rule, it's been our sort of observations that if someone has an onset of mitochondrial disease in childhood, more likely the primary underlying mistake in the gene will be in one of the chromosomal or nuclear encoded genes, whereas the reverse is if primarily the disease is of adult onset, it's more likely to be in one of the mitochondrial DNA genes. So that's just a slight point there. There are lots of problems with the current approach to diagnosis of mitochondrial disorders, and perhaps one of the biggest barriers we face is that clinicians actually need to have their radar switched on to the possibility of mitochondrial disease. And that's certainly something that the Mito Foundation is very much aware of and has been focusing a lot of its efforts in educating people, not just the general community, but clinicians at all levels about what it means or what it could mean to have a mitochondrial disease. In addition, many of the current screening tests that we use, you hear about blood lactate, for instance, are not absolutely robust in helping us to pinpoint who might have a mitochondrial disease or might not have a mitochondrial disease. And so lactate, for instance, is prone to all kinds of difficulties in terms of it sometimes not being present in patients who have mitochondrial disease, and sometimes being present, or often being present in people who don't have mitochondrial disease, but where it's elevated for other reasons. And Anu mentioned that there's work looking at trying to establish potential biomarkers. FGF21 has been one, GDF15 is another, and she's presented work on this, and Carolyn Sue has also done some nice work. Demonstrating the potential usefulness of FGF21 and GDF15, and we're doing some work in children as well. And then if, in terms of trying to establish a more definitive diagnosis, that often means, at least in children, having to resort to more invasive procedures, like muscle biopsies, MRI scans and so on. And in children, they're obviously not true, nor in adults, but in children, to do those kind of things, you often need to think about doing a general anaesthetic. And general anaesthetics, we know, have their potential risks in individuals with mitochondrial disease as well. And even if you establish an enzyme diagnosis, having done biopsies and so on, that may not lead you close enough to the underlying genetic basis of the disorder. And if we take an example, Lee disease, which is a pretty well characterized disorder from a clinical perspective, we now know that there are at least 80 different genes that can cause Lee disease. And so knowing someone has Lee disease doesn't necessarily put you closer to identifying the gene. So this is where genetic testing comes into play, and I won't go into detail about how we have done genetic testing in the past, but what I'd like to do is move on and talk about where genetic, or what we call now genomic testing, has moved in recent years. So you may have heard of the Human Genome Project. That was a huge international project that started in around 1990, and the aim of which was to sequence the entire human genome, so every single gene in the human body. That we currently think are around 20,000 or so. And it was a hugely successful project. The first human genome cost about $3 billion to sequence. But one of the outcomes of the Human Genome Project was that as time went by, the sequencing technologies, the machines, the chemistry that was used, and sorry, Doug, did you get that? No, I'll send it. I'll send it. Not too quick. The sequencing technologies and the capacity to analyze the data in terms of what we call bioinformatics pipelines had improved dramatically. And so you can see that, you know, by early last year, the cost in terms of reagent costs and so on of sequencing the genome had moved from $3 billion to about $1,000 US. So that meant for the first time, we now potentially can apply this technology in a clinical setting to help us make diagnoses more quickly. Just a couple of definitional things. You'll hear of genome sequencing and exome sequencing and panels and so on. So when we talk about genome sequencing, what we're talking about is sequencing every one of the genes, including the coding parts of the gene in yellow, the non-coding parts that are in white, the bits on either end, and also the mitochondrial genome, which is a separate genetic machinery. So that's what genome sequencing is. Exome sequencing is a sort of smaller version of that. It doesn't capture mitochondrial DNA and only sequences the yellow bits that code for the proteins in genes. And the reason people have done exome sequencing in the past has been, firstly, it's cheaper than doing genome sequencing, and secondly, you end up with about 100-fold less genetic information, which makes it much less complicated to then sift through all of that to try and find the gene that's causing the disease. And then another approach that has been used, again because it used to be cheaper, is what's called panel sequencing. So in this case, you take the known genes, genes that are known to cause a specific condition, like Lee disease, for instance, and you apply a next generation sequencing or genomic sequencing technology just focused on those genes. And each of these has their advantages and disadvantages that I won't go into now. But what it means is by having access to genomic sequencing of these sorts, there's a growing body of evidence, and we're very firmly of the view that there will be a number of huge advantages in terms of delivery of healthcare. Firstly, we'll get an earlier diagnosis, and our dream is to be able to apply this technology at an early stage in someone's presentation, and hopefully avoid the need for them to have biopsies altogether. We think that there will be a significant proportion of individuals that will be able to do that. The immediate consequence of establishing a genetic diagnosis is we now have very firm information about what the genetic basis of the disorder is, what the risks to other family members are or for future children, and so we can restore families' reproductive confidence, and that's an immediate thing that can happen. In some instances, knowing the gene that's involved has allowed us to be able to go straight to a specific therapy that has been of clear benefit. And an example I can give was a little child that was managed here who had a clinical diagnosis of Lee disease. That child was found to have mistakes in a gene called the thiamine transporter gene, and we were able to implement very simple therapy in him which halted the progression of the disease in that little boy. And equally importantly, he had a younger sister who was clinically absolutely fine, who genetic testing revealed she had the disorder as well, but had yet to manifest any symptoms. We started the treatment in her, and so far she remains symptom-free 2 years later. So there'll be some instances where this kind of establishing the genetic diagnosis will allow us to do that immediately, but that's in a smaller proportion of cases. In the majority of cases, by knowing the underlying genetic basis, we're in a much better position to look at what are the potential long-term issues, so that we can institute surveillance programs to look for early signs of those and jump on top of them and manage them straight away, and implement early intervention in terms of more general therapies like physiotherapy, OT, and so on. Ultimately, if we can prevent the diseases from altogether, like we in the sister of the boy I just mentioned, then that's absolutely fabulous. So in terms of, and so this technology is available in Australia. predominantly in a research setting, although it can be obtained clinically. And what we're really keen to do is try and make this technology available in an equitable manner around the country. You're all very familiar with the fact that the Australian healthcare system is a very complex beast, but with components funded both by the federal government and components funded by each of the states. So the federal government is responsible, for instance, for funding subsidised drugs and for meeting most of the costs of the routine tests that we do, like blood tests and so on and so forth. Whereas the states are responsible for managing or delivering healthcare through the hospitals. And unfortunately, most genetic testing, and certainly virtually all genomic testing, is not covered through the healthcare system. And so it means that it falls back to the states to fund that. And different states have taken different philosophies in the past to whether they fund it. And so in some states, there was a frequent situation where to get access to this kind of testing, families were having to pay out of their pockets for the testing, which we feel is an inequitable process and should not be supported. So a few years ago, we were successful in landing a grant from the NHMRC, which is the major funding body in Australia, to form the Australian Genomics Health Alliance. And in fact, that's what brought me down to Melbourne to help co-lead this. And this is a health services research project that's essentially based at looking at, can we deliver this technology in real time in the clinics and demonstrate clinical benefit? Can we demonstrate that there's a cost effectiveness in doing this, in being able to introduce this testing early on in the course of a person's diagnostic odyssey? Because at the end of the day, that's what governments are most interested in. Is this going, if we're going to fund this, is it going to blow out our budgets? And we also recognise that this is really what we call disruptive technology. It's one of the most disruptive technologies introduced into healthcare in the last decade. And so there are lots of practical issues involved in delivering this. And so we've got a program through our alliance of identifying what those barriers are, what issues are, and then ultimately trying to develop strategies and recommendations that we can present to government and policymakers in terms of how to deliver that. And one of the offshoots of all of this as well is, as part of Australian Genomics, we're building networks. So we built a clinical network around the country in a number of disorders, and we're building research networks as well, which ultimately will mean we'll be able to not only deliver the best healthcare, but we'll be able to ramp up the research capability in Australia in a number of these areas. So just to give you a feel, this gives lists all the sites, institutes, and so on that are part of Australian Genomics. And so we have over 400 investigators involved in the study, with at least 20 community groups that are active participants in this. And certainly the Mito Foundation is a very active partner in one of the flagships, the Mitochondrial flagship, and also Sean sits on our community advisory group, which keeps us honest in terms of knowing what the community wants out of all of this. It's not just what we think needs to be delivered. So the program, there are 4 broad areas of activity, and I won't go into detail into each of them. The main one that will be of interest to you will be this establishing a national partnership or national communications at a clinical level and in between the clinicians, the diagnostic labs, and the research groups. And in order to be able to get the information that we need, we have a number of so-called rare disease and cancer flagships that are embedded right across here, where we're recruiting patients directly from the clinic in real time, prospectively, and aiming to get as much information as possible about the potential value of the technology in that particular clinical setting. And again, this is a busy slide, but really to highlight that we have this lists here the rare disease flagships that we have and the cancer flagships that are part of Australian Genomics. And it's really pleasing that we were able to get mitochondrial disorders as one of the initial flagships to be funded through this project. And so just to focus in on the mitochondrial flagship and what we're aiming to do, we're very keen to evaluate the technologies that are available. So I mentioned whole genome sequencing, I mentioned whole exome sequencing, and at this stage there's information still to be gathered about which technology is going to be the most effective. And so the way the study is designed, half of the individuals that we'll be recruiting into this study will have whole genome sequencing, and the other half will have whole exome sequencing, and if that's negative, then we will sequence the mitochondrial DNA as a second test. And it's open to both children and adults around the country, and so we hope to be able to gather data with regards to the clinical effectiveness and the cost benefits in establishing an early diagnosis. To be able to include patients in the study, we have a scoring system, so there are a number of clinical features, biochemical features, and then imaging and enzymology testing if that's available. And this is derived from a group in Nijmegen that developed this scoring system, which we think is a good starting point. Listed here are the people who are involved in each of the states. So we have pediatric and adult clinical leads in each of the states, and they're the point people. So if someone wants to potentially be involved in this study, they can be referred through their medical doctors to these individuals who will then evaluate them, and then we as a group will review the application forms, and if they're accepted, then we'll allocate either to whole genome sequencing or whole exome sequencing of mitochondrial DNA. So where are we today? So far, of our 200 target individuals, we've approved just over half, 113, and analysis is underway or has been completed for a number of them. So far, we've got completed analysis for about 47, and we have a positive diagnosis in just over a third of them so far. There are others where they're still undergoing tests, and then there are others where we've got some tantalizing clues from the genetic testing, but we don't have an answer yet, and where we need to do further studies to prove or disprove whether these changes that have been identified, VU stands for variant of uncertain significance, by the way, whether these changes are actually disease-causing or not. And if we break it down to pediatric individuals and adult individuals and diagnostic yield, so far it's about 40% diagnostic rate in children, childhood onset disease, about a third diagnostic rate in adult onset disease, and so far whole genome sequencing is stacking up as being the better technique to follow. And I think in the longer term that may well be the way to go. It has been significantly more expensive than whole exome sequencing, but the cost of whole genome sequencing is coming right down even further. And so I suspect in the next 12 to 24 months, most groups that are involved in offering genomic testing will probably go the route of whole genome sequencing for a number of reasons. But the other point I would make here is that in about a third of cases so far, we've actually identified the causative gene has not been in a mitochondrial gene. It's been in a non-mitochondrial gene. And to some extent that might surprise people, but to another extent it doesn't. And I think that reflects the fact that many of the mitochondrial symptoms that are seen overlap with many other disorders. And so the beauty of this technology is if you don't find anything in the known mitochondrial disease genes, you can go back and reinterrogate the genomic information and look for possibility of mutations or genetic faults in other genes. This technology really has that power that you can go back and relook at it at different stages as our knowledge improves about new disease genes. And there are new disease genes being discovered all the time. So where to from here? The flagship, we've been given permission to continue recruitment until July of next year. We hope to be able to have the analysis of at least the sequencing data by October, where in terms of one of the things that the government wants in terms of judging whether something should go into the Medicare rebatable system or not is a health economic analysis. So one of the things we're poised to do early next year is do a retrospective review of what the diagnostic costs and management costs of mitochondrial disease in a pediatric setting had been prior to the genomic era. And so that's going to be undertaken at my old stamping ground at the Sydney Children's Hospital Network, the Children's Hospital of Westmead and the Randwick Children's Hospital. And that will be used as the sort of retrospective yardstick. And at the same time, we're collecting prospective health economic data for the individuals who've been recruited into this study. One of the things that we're very aware of is diagnosis and delivery of healthcare for mitochondrial diseases is quite variable around the country. And so in establishing this national network, we see this as potentially a great opportunity to harmonise approaches to diagnosis and management of mitochondrial diseases at the major mitochondrial centres. And so, again, there are potentially many barriers to this. And so we have submitted an application to the Mito Foundation that's under review at the moment, looking at where we're engaging with some really smart so-called implementation science experts who are people who look at the health system and identify barriers and how they can be fixed. So that's work that we hope to be able to undertake as well. And then what we're really excited about is that very recently the Mito Foundation has funded 3 clinical fellowships. So these are for doctors who want to specifically train in mitochondrial disease, so 2 pediatric and 1 adult, and these individuals will be really critical in helping to move forward in terms of harmonising our approaches to diagnosis and management. And so our hope is that we'll start preparing an application to the Medical Services Advisory Committee, which is the committee that decides whether tests should be funded through the Medicare system or not. So we'll start that process in July as we gather all this data, and hopefully in a couple of years' time we'll end up with a scenario where this testing is funded through Medicare and so people can get access to it. And I know Carolyn has been talking about doing the same thing for related to her adult clinic, and I think we've had some preliminary discussions about the prospect of doing a joint proposal to try and build the strongest possible case to make this happen. So I guess my concluding comments are, in terms of next generation sequencing for mitochondrial disease, we think it's a no-brainer that it will make the diagnostic odyssey shorter and less painful, and it will, at least in some cases, allow the institution very targeted treatments, but in others, and everyone, it will restore their reproductive confidence in terms of future risks. And so there currently is still an opportunity for genetic diagnosis through the flagship, and I encourage you, if you think you're eligible, to contact or have your doctors make contact with the clinical team that's involved in this project. I'm pretty sure the information is on the Mito Foundation website, so you'll be able to see if you're not from Victoria who you can access. And the next major challenge for us is to make this sustainable long term, because this is a research project that ends in a couple of years' time. We want this to continue, and so we're in very active discussions with the federal government in terms of how to make this happen. And on that note, I'll stop, and I'm happy to take any questions.
It's great to see not only that continuing on that theme of improvements in the diagnosis, but then how that some of that can have relevance at a clinical level, and then also underscoring the Mito Foundation's recent financial commitment at the clinical side in the, as John mentioned, awarding 3 clinical fellowships that will be starting first thing next year, really to look at boosting patient management and patient outcomes ideally there. So are there any questions?